Jean, this is the handicap with broken English, but we share this fate, the two of us.
Thank you.
Dear colleagues, ladies and gentlemen, at first I would like to thank Dr. Christa Maar, as the CEO of the Felix Burda Foundation, for her impressive commitment in improving the colon cancer prevention program, not only in Germany, but meantime in Europe. And I guess you get our highly appreciation. The second thing is that before stepping into the German colon cancer prevention program, I would like to remind you of some facts regarding colon cancer in Germany. We have 70,000 new diseases every year. We have a small decline in the numbers of people dying from the disease, now around 27,000. Not on the cancer prevention, but on the medical treatment edge regarding the disease, Eric van Kutzem and I, as GI oncologists, know that there is some progress. We now know that in the stage 3 disease after R0 resection, adjuvant medical treatment can save further 20% of lives. We now know that people with a progressive disease are expecting a median overall survival of 24 months and even more. And we know that novel therapies, particularly including molecular therapies, will further improve life expectancy, and perhaps one day progressive colorectal cancer will become a somehow chronic disease, but a disease which ultimately will come to death. But this has a high price. As mentioned already this morning, the price of medical treatment now, when you take all the medical possibilities, including the molecular therapies, is around 150 to 200,000 euros per treatment. And you only can expand life expectancy, but you cannot save people. So the task, and I'm particularly looking to Dr. Valigora, the task for the European authorities is to wait out where they want to invest the money. In the progressive situation, and we cannot refuse treatment to people suffering from the disease, or to prevention. And before we start the academic competition, what prevention strategy is the best, I remind and I quote Sidney Winawer saying the best screening step is the one that actually is done. So that is our main focus, I guess. So what about Germany? Before October 2002, we had the annual FOB testing offered to all people over the age of 45. It was the work of a concerted action of many allies, and Dr. Maar was at the leading edge, who convinced politicians and other authorities in Germany to launch a screening program starting at the age of 50 with the annual FOB testing, and then at the age of 55 offering to all German citizens screening colonoscopy that, if negative, could be repeated at the age of 65, or alternatively the biannual FOB testing. At first, we were surprised, and these are data from the Central Research Institute, which are highly acknowledged at this time. The Central Research Institute is a subsidiary of the Society of German Professionals, and they keep all the data monitoring, and give us always an up-to-date impression on our screening programs. The first observation was that there was a decline of FOB testing, most presumably to the switch in the lifetime. The program now started, age of 50 compared to 45 previously, and the biannual instead of the annual FOB testing in the up-to-date program. Who can perform screening colonoscopy? These are gastroenterologists or internists, surgeons, or even pediatrics, but all have to prove a training of colonoscopy before they can enter actively and participate in the program. There are different quality issues. The physicians entering the program have to prove their quality and skills in a number of colonoscopies and polypectomies. They have to prove this further on in maintaining their colonoscopy license. And every investigation, every endoscopy has to be documented, and there is a rigid infection control to prevent hygienic or infectious hazards to the people. Dr. Birkner, I guess, will focus on this in his talk. What are the reimbursement conditions? You see that a complete colonoscopy is currently reimbursed with 188 euro, and the other, the polypectomy, the pathology, to a smaller amount. FOB testing is hardly reimbursed, if at all, and what I regard as a critical point is that the education about screening is somehow neglected, and perhaps adherence and other issues are influenced by this attitude. Up to now, we have more than 2.1 million German individuals having undergone screening colonoscopy. We have more than 2,000 skillful physicians who can perform screening colonoscopy. Clinical institutions have been excluded from the program. This is to budgetary reasons. More females than males have been adherent to the protocol, and the median age are 65 years, and for females 64 years. There have been the vast majority of people have preferred to undergo screening colonoscopy with sedation. The results of the German program up to 2005 indicate that there is a cancer detection between 0.6 and 0.8% of within the screening colonoscopies. Around 30% polyps have been detected, 20% of those were adenomas, and around 6 to 7% advanced, that means critical adenomas that had been removed. What is really impressive is that when we compare the tumors diagnosed with epidemiological data outside the screening program, where we see that the vast majority is in the progress states, that means UICC 3 or 4, we see a stage shift, particularly to stage 1 with an excellent 5-year survival prognosis, and to the stage 2, that means both are lymph node negative, harboring a very good prognosis for those individuals undergoing surgical resection of the tumor. Regarding the complications, it's always very critical in screening situations to outweigh the risks versus the benefits. We compare the data of the data of the German experience with large trials from David Lieberman, from Dr. Imperial, or from Wendy Atkin, who is in the audience today, and you see that regarding bleeding and perforations, the large-scale German trials fits within those complications reported in these trials, with a little exception that in the therapeutic setting, and that is very easily to understand, when you remove polyps, there's a little increase regarding bleeding and a little increase regarding perforations when compared to the diagnostic setting alone. One problem regarding screening colonoscopy is perhaps well illustrated from experiences in the States. In the States, the same program would expect more than 40 million people, and in 2002, indeed, 14.2 million colonoscopies had been performed. There's still an unneeded capacity of even more than 8.2 million colonoscopies possible. But what we see is that 25% in this US experience of colonoscopies beyond the age of 55 years are surveillance colonoscopies after polypectomy. And this is particularly critical in the diagnosis of hyperplastic polyps that had been removed, because 24 of the GI colleagues and even 54 of the surgeons recommend surveillance in this situation where the recommendation can be intensively discussed. So I would like to return to the, no, that's, sorry, that's nice. So what is the situation in Germany currently regarding the post-polypectomy guidelines? We have a follow-up colonoscopy recommended 3 years after complete removal of an adenoma independent of number, histology or size. And we have a follow-up colonoscopy recommended 5 years after negative post-polypectomy colonoscopy. But to reduce the endoscopic work burden regarding post-polypectomy management, we are now underway to update the evidence-based recommendation, and this process is now underway. So I come to my last slide. I hope it works. I don't know what it needs more than to press the button. What are the challenges? We have still a low compliance in the screening colonoscopy. We would like to have more data on 30-day morbidity data. We have a deficit in the identification and care of risk groups, and I'm very excited about the talk Dr. Vazen will give us from the Dutch experience this afternoon. We need to have a critical view on the post-polypectomy management. We have to reinforce the FOB the testing rates, and we have to discuss critically whether FOB testing as an alternative to screening colonoscopy is really to be recommended only biannually. And I thank you for your attention.